All right, next up, integumentary physical therapy. What's integumentary? Skin system. All right, good. And now at this point in anatomy, you guys have covered the skin, right? Yeah, anybody taking anatomy one? So, pretty important because one, it's the biggest organ of the body. Two, the functions of the skin, protection from physical and chemical invaders. That is the number one thing we have to worry about whenever there's skin compromise. Is now that person has at high risk for infection. Other things, sensation, thermoregulation, excretion of sweat, vitamin D synthesis. And I will tell you, what do you think your patients are going to care most about whenever we're talking about skin injuries? How they look, the cosmetic, is this going to scar, right? That is going to be the question you will answer every single day of your career. And that cannot be understated. So just quickly, three main layers of the skin: epidermis and dermis, and the subcutaneous or hypodermis. Epidermis has the 5 sublayers. Outermost layer, excuse me, mostly dead skin cells. Innermost layer acts as a filter for substances moving to and from the dermis. Avascular layer receives nutrients from the basement membrane via diffusion. All of that's review at this point, right? Some yes, and some said, I forgot about that. Who forgot about all this information the second they passed? No? All right. I'll try to be specific on how in-depth we're going to be for our exams. I'll look at that. Remind me, and can you email me next week?
Yeah.
About double checking how in-depth do we need to know about the anatomy of the skin for the next exam, okay?
Everything you did was like cellular level
Yeah.
class that I was.
And not broad here. Okay. All right, well then let's spend a little bit more time with this. Sorry, I thought that was going to be review. So the epidermis, outermost skin layers, and it's avascular. There's no blood supply to it. The dermis is the thickest layer, the middle part right here, if we see that. 2 sub layers to it, papillary and reticular. So this dermis is highly vascular, great deal of moisture, very pliable. Also houses all of the skin appendages like hair follicles, nail beds, glands, other things like that. Subcutaneous tissue, also known as hypodermis, so those terms you can use interchangeably. That's the innermost layer. That contains adipose tissue. What's adipose tissue? Fat. And fascia, lymph vessels, some sensory structures as well, and that's highly vascular. So there's a more blown up picture of it. Pretty fun. So we are going to see patients' wounds from a lot of different sources. I don't think I put a lot of real life pictures in this PowerPoint, but if anybody gets squeamish, feel free to step outside or look away. My friend Pat McCormick, one of my best friends, I went to grad school with him. Anytime we talked about blood, he would immediately, he was a front row guy. Where did I sit? Where do you think I sat? Yeah, I was a back row guy, right? So he would be in the front seat and I would be in the back, and he would, the second anybody would start talking about blood, and it didn't matter in what context we were talking about blood. If we started talking about the biconcave shape of red blood cells, he would immediately stand up, go in the back, lay down, and put his feet up on something. He would just be ready to, and I busted his chops about that just a few weeks ago because I told that story to my other class, and he replied, you can't fall on the floor if you're already there. So, because he would just pass out, he gets so freaked out about it. So if anybody's like that, feel free to step out. I'll give you Pat's number. He'll talk you down from it, and we'll be all right. But wounds can come from many sources. We're going to spend most of our time on pressure wounds today. We also have some vascular compromise that could do it, but even surgical incisions, every single aspect of physical therapy, I don't care where you're going to work. My wife works in the school system with pediatrics. She has kids post-surgical that she needs to be aware of. How is this tissue? So it is really important for us to protect and promote healing. So the basic goals of wound care is number one, protect the wound and surrounding tissue from additional trauma, provide optimal environment for healing, reduce stress or strain on tissues around the wound, protect the tissue from mechanical stress or movement. I mean, basically we're saying the same thing over and over again right there, right? Protect that wound, protect the healing of that wound. Here is important, reduce the number of microorganisms in and around the wound and decrease the formation of scar tissue. So quickly through wound healing, what you will need to know for this is just what the phase is, how long it lasts, and what's the big function of that phase. And I guarantee, has anybody ever had a wound of any kind, whether it's a bug bite, a scrape, a cut, surgical incision? I think everybody at some point in their life, if you've ridden a skateboard, yeah, whatever, when you fell off and you scraped your knee, right? That counts. So the first phase is the inflammatory phase. It initiates the wound healing. What does the inflammatory phase do? Initiates the wound healing. Very good. Just a little bit more energy next time. It's going to last between the day 1 and day 10. And it's going to limit tissue damage. It's going to remove injured, damaged cells, and it's going to begin repairing injured tissue. Next phase is the proliferative phase. This is going to start forming new tissue. Starts somewhere around 3 days and then ends 21 days, roughly. These phases do have some overlap to it. So we can have granulation where new connective tissue forms around the wounds, and then angiogenesis. Before we read that, who can break down that word for me? Who's in medical terms? Angiogenesis. Tough one.
That's a pain, right?
No. Are you thinking of angina? Yeah. Formation, new. Yep. And angio is going to talk about the blood tissue. So new blood supply reestablishes in the capillaries. So that's pretty fascinating. That new blood growth, new vascular growth. Pretty cool. And then the wounds are going to get smaller. And then we have, lastly, the remodeling phase. That's the fiber reorganization, the scar shrinks. That's going to last up to 2 years. Now, the newly repaired tissue will have roughly 15% of the pre-injury tensile strength to it. So still pretty weak. It will grow to reach over 80% strength over time, but initially it's still very weak. So when we look at our patients, especially post-surgical, and they're 3 weeks out, and this is looking great, look how great this incision looks, we have to really educate our patient. Yes, that's true, but we have to protect this. It's going to take up to 2 years for that tissue to heal. And I'll tell you a horrific story. This happened to a patient of mine before I started working for him, with him. He had a knee replacement and he's doing great. Roughly 3 to 4 weeks after, he comes into the clinic, he starts on the bike, and the bike is great because it can slowly bend the knee, right? Going on a stationary bicycle. And he decides, and he's one of these, and who's a tech here? How many techs do we have here? You guys know it's the neighborhood guy, like the guy that's always there. He's been a patient off and on for 3 years. He just kind of walks in and he knows like he's going to help himself to coffee, and like, he's a great guy. He's just always there, right? So that's kind of him. And he walks in, he goes right over to the bike. Hey guys, hey. And he decides to lower the seat of the bike what's that going to do for the amount of knee bend? It's going to be more. And this is a tough guy. He wants to get better, and he cranks that knee. And because the incision straight over the knee, because it's only 50%, 15% pre-tensile strength, he split the surgical wound wide open, had to go get a stitch back up. Now it all like starts over again. Huge problem because the risk of infection is now sky high. He was doing fine. Now we're really afraid of infection. Can tell you some other horror stories about other people that things have happened to, but we'll save those for some other time. So let's just recap. Inflammatory phase, first 10 days, it initiates the wound healing. Proliferative phase starts forming new tissue. One of the big key words that you should know for is granulation and angiogenesis. Days 3 to 21, and then fiber reorganization shrinks the scar up to 2 years. So we talked a little bit ago about progression of exercises during the treatments. And I will also tell you, for that guy, he was progressing his own treatment, right? I want to bend the knee more. And it's up to us to say, no, you're doing great. Let's just keep doing great. Let's let this heal. Let's let this get stronger and stronger before we start cranking on this motion here. So I will just say, we are special in the PT world that we are going to see more of our patients' skin than most other healthcare providers. Now, how many of us on our annual physicals, the docs have skipped the skin screen? Docs should be saying, okay, let's remove all your clothing and let's do a top to bottom skin screen. How many docs are not doing that? I see a lot of nods. And okay, so okay, they're busy. Fine. We might be the first person to actually examine the skin on their back, because we have to examine the skin on their back. One, if they have some sort of muscular problem, we want to see what's happening, right? Two, we need to screen the skin before we apply any modality, like a hot pack. For our techs, how often are hot packs used? How about ice packs? Right? So before we apply any sort of modality, hot or cold, we should be screening the skin just to make sure the skin can withstand that temperature change. So we might be the first person to ever screen their skin. So we are in an opportunity to catch things that are abnormal that the patient has no idea about. So catch wounds early, screen for other conditions like skin cancer, and we get to educate our patients on how can they protect their skin as well. So some of the screens that we're going to learn today are the skin screen in general, just a nice broad skin screen. We're going to be seeing it for our patients. We want to make sure the patients are able to withstand a hot pack. We're going to use what's called the C-triple-T-Me. And we can also screen for cancer. Now, none of us could know what is this cancerous or not, right? What is this freckle? What is this mole? But what we do want to do is we want to have a tool that helps us decide when something is safe versus unsafe. When do we call their general practitioner and say, hey, there's a spot here. Before I can do this treatment, you need to look at this. So we'll look at that. And then we'll just talk quickly about how do we actually measure a wound, because we talk about safety for these other reasons, but we also want to know what's the other reasons why we measure things, to measure for progress, right? So we're going to be measuring wounds to make sure that they are getting smaller and smaller, because if they're not getting smaller and smaller, what do you think the problem might be? Infection. Infection is likely the problem if it's not getting better. So we'll look at that. So here's screening the skin. Could be very specific, like, okay, you just had this surgery. I want to look at this area of your skin, or it could be just global. So the first thing we're going to look at is color. It should be uniform. Skin color should be uniform. It should be uniform proximal and distal and left versus right. So there's a few things that we could look at. Cyanosis is bluish tint, often in phalanges. What are phalanges? Fingers. Yeah, everybody did spirit fingers. That was pretty cute. It also lips and could be the other one. So it could be a sign of advanced lung disease, right? The lungs are not delivering oxygen to the body, and now we're going to be turning blue. It could be just reflexive, right? If we're cold, like today's a cold day, before Rose let go of Jack. Jack was pretty cold, right? Yes, who doesn't know Rose and Jack? Like some people are like, I don't know what you're talking about. Yeah, yeah. So that is what cyanosis is. Jaundice is yellowing of skin and eyes. Arrhythmia is reddish color. Now that shows increased blood flow. Okay. Would we expect increased blood flow right here or not? Like, why is this increased blood flow happening? Excuse me. And the first thing that I skipped was hemosiderin staining. So that's a rusty kind of brownish color, typically in the distal lower extremities. And that happens when blood pools in the legs. When blood is stagnant in the legs, the iron-containing pigment in that blood can stain the skin. So that's what this picture is. If you look, we don't have a right versus left comparison, but look proximal versus distal. Is that skin uniform? No, way darker distally towards the ankle than proximally here, right? So who had a question? Yeah.
Like the spots like on old people.
No, I don't know the mechanism of those darker spots.
Okay.
No, it's not hemosiderin staining though. Now, why is it typically in the distal lower extremities? Farthest from the heart and gravity. Gravity pushes blood down. For some reason, it's not returning. Gravity's going to keep it wherever it is. So, but yeah, that's a nice picture of hemosiderin staining. Next thing we would look at is temperature changes. Temperature, again, it should be uniform. Should be uniform right versus left, proximal versus distal. If it's hotter or colder in one area, we've got to think why. First thing, if it's colder in one area, if it's colder on my left foot than my right foot, what's your worry? Decreased what? Decreased blood flow. We got to figure out why. Because does anybody think decreased blood flow is a good thing? No. All right. If it's hotter, warmer, I should say, on one side versus the other, what's the probable reason for that? So we're worried about infection. It's the probable reason is increased blood flow. And we're worried about, okay, is this potentially a sign of infection or not? So again, we have to screen the skin to figure that out. Texture, is it smooth or rough? Turgor is the skin elasticity. Basic hydration test, not to pinch, we're not going to pinch, but take some skin off the back of your hand and just gather it. We don't say pinch because we don't pinch our patients. No, I didn't pinch her. I gathered her skin. So you give it a little pucker and then let it go. And we time how much time it takes to rebound. Now, if it stays puckered up in greater than 3 seconds, that would indicate some dehydration there. And I actually use that aspect of this Turgor test all the time with my patients. My older adults, we talked about incontinence and how patients will stop drinking if they're incontinent or if they are on a diuretic. My patients are dehydrated all the time. So whenever I come in, especially on the hot days, today's not one of them, but on the hot days when they're saying, "Oh, I'm tired, I'm just weak," do a Turgor test. You say, before we do anything, we're going to drink 3 glasses of water because you are severely dehydrated right now. So that's a great test. Moisture, again, it should be slightly moist, not dry or excessively wet. And then edema and effusion, we didn't cover earlier, but edema, how much swelling is there? Again, in some ways it can be predictable, but it should be uniform. So that's what the skin screen is. C-triple-T me. Next up is screening for cancer. So nobody is good enough to just say, I don't like the looks of that. All right, well, we need to be a little bit better than that. So we use the ABCDE method. ABCDE method to screen for cancerous cells. First up, that mole freckle should be symmetrical. So we look at A, asymmetry. It should be round or oval. Next up, B, borders should be smooth, regular, and defined. Color is next. Uniform color that's either tan or brown. The diameter should be 6 millimeters or less, about the size of a pencil eraser. Does anybody use pencils anymore? So that's, I'll have to change that to stylus maybe later. And then evolution is something that we're going to want our patients input on. It should be non-changing. So let's do this. Let's do this one right here. And a second one down. Who can tell me what they think about this? Not symmetrical, right? It should be round or oval, not. Good. What's next? All right. Good. Discoloration, but we skipped something. What's the one that we skipped? Borders. All right. So anytime we have a tool, we should be using the tool in the same way every single time. It doesn't matter if the first thing that jumps out at you is color. Well, then you have risk of missing something. So start with A and end with E when we do this, okay? So, all right, so we said first it's asymmetrical. B, borders, what do you think? They should be what? Regular, well-defined. Do you think this is well-defined? No, it kind of is like just all over the place here. So not well-defined. You said color, you don't like. What color should it be? Brown or tan, something like that. What color does it look more on the red side? What's next? Diameter. So we do have a little bit of this ruler here. What do you think? Too big. Yep. And then evolution, we would need patient's input on. Let's go this bottom right one on here, right here, this one here. Who wants to work their way through it? Oval shape. So A, not worried about. B. Come on, don't skip B. Borders. That's all right. Borders, what do you think? Well defined. Yeah. Yeah. Now it's the color. Color looks appropriate. And then diameter, we don't have a ruler on this one, and then evolution, we need patient feedback. But yeah, we see something like this. Proceed, not a problem. See something like the first one we talked about. Okay, that's a stop. That's we got to go see the doc. And that's important because one, we might be the first person to actually do a skin screen to somebody. Two, some of our modalities that we use, if there's cancerous cells, can increase the speed of growth of those cancerous cells. And that's not something I would really like to do for my patients. So we want to be really sure about that. Plus, also, I'm not an expert at every single cancer, but cancer can cause pain too. So maybe their shoulder problem isn't really a shoulder problem. Maybe they have a cancerous problem that is just causing shoulder pain. I have had that happen to 3 different patients of mine. They were all smokers. They all had shoulder pain. All of the shoulder pain was not getting better. Sent them back to the doc. The doc took an x-ray of the shoulder. X-ray looked fine, but if we take an x-ray of the shoulder, the lungs, just a little piece of lungs also gets captured. And all 3 of those had little spots in their lungs that said, okay, we have to go check this out further. That's how a lot of lung cancer is discovered, is with shoulder x-ray. So, lung cancer, we don't have this ABCDE method for, but it is a really important tool for us to know, okay, this is not a physical therapy problem. Anyway. Any questions on that ABCDE method? Yeah.
What if it's asymmetrical with weird borders, said black and red, but it's under 6 millimeters. Could you just-
Any one of those I don't like. Any one of those, and again, so the question was, how come? What if there's only one of those 5 or 6 things that are off? Okay, good question. Any one of them is off, I am concerned and I am calling the doc. Because
Also find some staff on something too.
absolutely, yes, and we're not gonna get into that, like, we could always find staph infections, ringworm, impetigo, there's a whole bunch of other things that we could find when we do skin screening. But for the ABCDE method, our careers are always risk reward, cost benefit, right? What's the risk of saying, only one of these looks weird, the rest of them look fine? What's the risk? Patient actually has cancer and we said, no, that don't worry about it. Versus, listen, only one of these things are a problem, but we've got to make sure. Now we're going to make sure we're not missing anything. So yeah, it's our job to be really careful with this kind of stuff. There's no benefit to not being. All right, so quickly with wounds measurements, we would use a tape measure hovering over the wound, or there are also sterile measuring tools too. And what we would do is, if the patient does have a wound, we would measure the length at its longest point, the width at its widest point, and then the depth at its deepest point. Now, some of these tools look like Q-tips. They're sterile Q-tips with, on the stem is a ruler that's printed on it, and you stick that right into the wound to measure the depth. So that's pretty fun. Anybody here love the idea of wound care? I usually get one person to be like, yeah, I think I could do that. Yeah, maybe. All right. Oh, you should see some of the wounds we see. I'm not a wound care. I do not want to do any wound care. Some of the wounds that we see are fascinating. We'll get into some of that in a minute. So we just document length, width, depth, and that can be really important for signs of progress. That's the big reason we're going to be doing that. We can also stage the wound if it's a pressure injury. So if it's a pressure injury, pressure injuries happen. Let's talk about pressure injuries first, and then we'll talk about staging them next. So the anatomy is the integumentary system involved. That's the answer for all of this, but it varies depending on the layers of the skin involved. What happens is prolonged pressure on bony prominences create these pressure injuries, which can develop into wounds. So what happens? So on these bony prominences, so as I sit here and I rest my elbow on this armrest here, what's happening to the blood vessels under my olecranon? They're getting constricted, right? I'm squeezing them. There's no blood flow. All right, if there's no blood flow, what's eventually going to happen? Maybe not numb. I mean, that can't happen if I'm resting on my ulnar nerve, if that's what you're thinking of. But I'm just talking about the skin. If there's no blood supply to any tissue, it's going to die, right? So that's what happens with pressure injuries. There's prolonged pressure on a bony prominence. That bony prominence now has a high pressure that's enough to restrict blood flow. If it's restricted enough and for long enough, the tissue dies. And that yes, bed sores are pressure injuries. Also known as pressure ulcers. Yes, those are bed sores. So the risk areas will depend on what position they're in. If you're seated versus supine, do you guys know what position that is? Laying on your back versus prone is laying on your, versus side lying is laying on your side. So each position has its different points that we'll look at in a minute. But it doesn't take long to develop these pressure injuries. It can happen in as little as 2 hours. So we the treatment for it, first of all, it's a static problem once you discover it. So once you change your position, it's a static problem. Now we just have to fix that problem. It is temporary, hopefully. Although I had some patients with pressure wounds for years that it took years to heal. It can last a long time, but hopefully they do. So the treatment for it is number one, prevention. Prevention is the most important. Changing position every 2 hours is what's recommended. Adding cushioning can help because cushioning is decreasing the amount of pressure, right? The chair that you guys are sitting on right now, hard, lots of pressure, versus the cushioned one that I'm sitting on. You got one back there if you wanted to steal that one. Versus the bed that you sleep in, right? A lot softer. So we could add cushions to decrease the pressure, or we could what's called bridge bony prominences completely. So you guys ever see those little inflatable donuts for sacrum and coccyx? So if I put one of those inflatable donuts underneath my elbow, now the skin under my olecranon is completely off. There's no pressure whatsoever. I can't get a pressure injury without pressure. A little bit different if I just added a pillow to this armrest. All right, the pillow is going to help, but you're still at risk because there's still some pressure. So that's what I mean about cushioning versus bridging. Does that make sense to everybody? And then next, we could do wound debridement, which is removal of dead tissue. We have to do that. We have to remove the dead tissue out of the way so that new tissue can grow and they can heal. So I want to go back to staging of the wounds of these pressure injuries. So stage one, we call these pressure injuries. I should have changed that to away from pressure ulcers and away from bed sores, because a stage one, the skin is intact. The skin is not broken. It's just non-blanchable arrhythmia. So that's what this cartoon looks like here. It's just an area of redness over a bony prominence, but it's non-blanchable. So blanchable means if everybody grabs one of their fingers, gives it a squeeze and then lets go, your skin should turn pale and then it returns to its original color. Non-blanchable means we press on this. Hey, that's an area of redness. We press on it and it does not blanch. It does not turn pale. It stays that reddish color. So whenever you think, that's like a key word. So when you see angiogenesis, you're going to think which stage of healing of wounds. Yep, and what was the name of that? Proliferative phase, right? So there's some words that you just need to attach. This word non-blanchable, if you see non-blanchable skin, you are talking about a stage one pressure injury or pressure ulcer. Okay, that is the key word. Now a stage two, a little bit worse. That's a shallow crater. Most of these look like broken blisters. Anybody ever have a blister that broken? It's just really superficial. But what's the problem? What's the danger of between a stage one and a stage two? Breaks through the skin, and what's the problem with that? What's the risk? Infection, right? Stage one, all right, great. Let's make sure this doesn't turn to a stage two, because if it turns to a stage two, we have high risk of infection. So stage two, not very good. We've broken the skin. We no longer have that protection of that that chemical or pathogen. Stage three is now deep. Deeper crater involves the epidermis and the dermis. So now here's that picture. We're into the dermis. But deeper structures like bone, tendon, and muscle are not visible. Stage four, really deep crater. Necrotic tissue could be there and visible. What's necrotic tissue? Dead tissue. But here's the big difference. All layers of the skin are involved and it exposes bone, tendon, muscle, those deeper structures. So that's what a stage 4 would be. And then lastly would be unstageable. There's this tissue here, it's kind of black leathery tissue. That's called eschar. That tissue needs to be removed in order for us to know how deep the injury is. That's necrotic tissue that's getting in the way of healing. So that would be unstageable. Hey, this is bad. I'm not sure how bad because I don't know how deep this goes until we remove the thing that's blocking me looking at this. So here's my, so on a written exam, I think there's some keywords that for each of these stages that you should know. First of all, non-blanchable, stage 1, stop reading the question. If you see non-blanchable, it means stage 1. The keywords, you know, shallow, broken skin, broken blister, type of like really shallow but broken skin means stage 2. Deep but not deeper structures would be a 3. And then the deeper structures exposed, you automatically know a 4. Now, here's the other thing. So sometimes on exams or, you know, in real life and clinically with patients, I'll look at a wound and I'll say, all right, well, that's a wound. But then I've got to tell my nursing staff or the docs what the type of wound is and what stage it is. So here's my process. So some of these I just don't know, especially in the younger, you know, whether you're in school or the younger clinician. So my thought process is my first question is it superficial or deep? Because if it's deep, what am I deciding between? 3 and 4. Does anybody think they could look at any wound and with their gut feelings say, is it superficial or deep? I think right now you'd be pretty good. Yeah, sure, there'd be a couple in the middle that you'd probably guess wrong on, but I think just with that question alone, we'd make a pretty good guess. All right, so once we know it's deep, we're choosing between a 3 and the 4. What's the difference between a 3 and a 4? Bone, muscle, fascia, tendons, any deeper structures exposed or not. So you break out your flashlight, you look, poke around maybe. Don't poke around. Not without gloves on. Put gloves on first, then go poking around. You don't see deeper structures. What stage 1 do you have? 3. If you don't see deeper structures. Okay. So new patient, new wounds. Hey, that's superficial. My choices are now what? 1 or 2. What's the difference between a 1 and a 2? Make it easier. Is the skin intact or not? If the skin's intact, we got a 2. If the skin's intact, we have a 1. If it's not intact, we've got a 2. So sometimes when I look at wounds, and sometimes exams have pictures of wounds, and I always hated that because the picture never is clear enough to really see. But all right, go through this process. But with real life, with my real patients, this is the process that I go with because I'm not a wound expert. But that's exactly what I use.
Here's how much pain they're in to judge. Like if somebody's
No.
taken out with a 4.
No, and you know what? That's a great question. Can we use pain as part of this? Most patients who have pressure injuries do not feel pain in that area. And that's one of the reasons why they get pressure wounds. So that actually brings up a great point. So if these pressure injuries happen as little as 2 hours, I was teaching from 8:30 in the morning till I came here. My students were sitting in their desks with a couple of breaks. I gave them some bread for lunch. They were allowed to get up and move, but for the most part, they were sitting in their chairs for 6 hours today. How come every single student doesn't have a pressure injury? How come you guys don't have pressure injuries after we have class for 2 hours in a night? So 2 hours it's not really long enough. My students were in class 6 hours today. You keep moving. Why do you keep moving? You get uncomfortable. Why are you getting uncomfortable? Blood is starting to restrict. That becomes uncomfortable. Your body says, get off this butt cheek, and you slide, you lean back, you come here, right? You guys are moving all the time without even thinking about it because your body is saying, hey, this is starting to be uncomfortable. And the brain says, it better move, right? So that's why we don't get pressure injuries, even if we were to sit in this class for 6 hours all in a row. The patients that get these lack sensation that tells them to move, or they lack the ability to move. That's the other one. But most of these patients that get these don't complain of pain because they can't feel it. Yeah. And that's what makes poking these wounds okay, because they can't feel it anyway. So pressure injuries, so we know pressure injuries happen over bony prominences. People who have taken anatomy right now. Did you go over the skeleton yet? The bones yet? Doing it now? Okay. So as you guys are sitting right now in your chairs, what bony prominences are at risk? Now, the way to think about this is to start either from the top and kind of start thinking about the anatomy as you work your way down, or drake it, work from the bottom and work your way up. Okay, so whichever way you want to do it, I don't care. But start thinking about your anatomy as you're sitting there. Start at the top. Let's start at the top. In your position, head, anything with the head? Neck, anything? No, no contact. If you're in a recliner, now that our heads are in contact, now the back of the head, the occiput could be a problem. All right, keep going down. What's the next anatomy that's the first anatomy that is at risk? Scapulas and the spinous processes of the vertebrae. Good. Keep going down. Next up, probably down towards the pelvis. Anything with the pelvis? Maybe the sacrum and coccyx, depending on your exact sitting position. If we're reclined, yes, definitely coccyx and sacrum. As you guys are all pretty much sitting right now, really, really good. Less of a problem, but we do have ischial tuberosities are the number one risk area when we're seated. And that is the thing that we have to warn our patients who use a wheelchair for locomotion to be vigilant about offloading their pressure on their ischial tuberosities. All right, keep going. There's one other major one. Heels, the inferior calcaneus is the next major piece. Now, depending on your elbow and position, maybe olecranons from there. All right, let's think if we're supine in bed. Start from the top. Occiput. Keep going down. Scapula. Keep going down. Spinous processes. Keep going down. Pelvis, particularly now, maybe the PSIS. That would be the big bony prominences if you haven't gotten there yet in anatomy. Good. Keep going down. Sacrum now, probably. And then all the way down now to the posterior aspect of the heels. Let's flip it over. Prone. Start at the top. Zygomatic arch, maybe mastoid process, maybe mandible, depending on how you're positioning your head. All of those bony prominences. Yep. Especially you with those big cheekbones. Big model cheekbones. Such a risk when you're in prone. What's next? We're doing pretty good on tangents. That was my first major tangent. That was pretty good. We're prone to the anterior aspects of the shoulder. Okay. Where else? Maybe clavicles. Where else? Maybe sternum. Good. Where else? Maybe ribs. Good. Where else? Now we're on the ASISs. Good. Where else? Patellas. Anywhere else? Maybe the top of the foot, depending on their exact positioning. Maybe. And actually, maybe medial malleoli, medial ankles, if they sleep kind of splayed out. So that could be it, depending on their exact positioning. Side lying. Starting at the top. Probably still jaw and zygomatic arch and mastoid processes. Probably nothing up at the temporal, but maybe. Good, so probably all right here. Next up, definitely lateral shoulder of the side that we're laying on top of. Keep going down. Lateral ribs, keep going down. Hips, specifically the greater trochanters, maybe the iliac crest. I will say the seated with spinous processes, some of us in here won't have to worry about that. I had one patient, she was extremely kyphotic, right? Really bent over. She was 99 years old when I treated her. And if she broke 80 pounds, that was a really good day for her. So she was really, really frail. Her spinous processes, again, kyphotic, no body mass. Every single spinous process on her is a high risk. For me, I've got muscle mass, I've got adipose tissue, I don't have a kyphotic spine. I can sit in this chair and not have my spinous processes be at risk. So some of these things you're saying, like iliac crest, I don't have a problem. I don't have a risk for iliac crest. Some of the thinner people will. So, it is body specific, but those are good areas to think of. All right, so we're still in side lying. Iliac crest, definitely greater trochanter. That's a big one for everyone. Keep going down.
A little ankle bone that sticks out.
Good. You skip something though. You're in it. So the knee. So we have the lateral aspect of the bottom leg. Where else do we have? Both medial knees if they're stacked on top of one another. Right? So then you want to go down to the ankles. So the lateral malleolus and also both medial malleoli if they're stacked on top of one another. And then maybe the fifth metatarsal and the one that's on the bottom. Maybe potentially. Good. So I got to tell you, so because you learned about pressure injuries and how they happened, and because you already had anatomy knowledge, you already know the areas of that risk without me teaching you. You already knew it. You just had to combine the information that you already had. Isn't that great? Now, here's my exercise for you. Your patient was seated for the last 2 hours. What position would be next for them if you're going to change positions every 2 hours?
Standing an option.
We can if you want it. If your patient has been seated for the last 2 hours, they need a position change. What position are you going to suggest to them if we're going to prevent pressure injuries? I got to vote for side lying. Yeah, I think prone and side lying are the two best options. Why wouldn't supine be the option? Because we're not relieving pressure at the scapulas, the spinous processes, potentially sacrum and PSI. We're not relieving that pressure. No, we just did 4 hours of pressure in a row for those areas. So yes, the next position should be a complete relief. So great thought.
Does it reset? So if you get them up and they walk for 20 minutes, would you have them sit back down?
Some of that depends on the patient's overall health. I wouldn't, because once we get a pressure injury, they're really slow to heal, and the risk of infection is sky high, especially when they're around the pelvis. There's a lot of bacteria there that we'd like to stay away from. So good. Any questions on pressure injuries? So the next thing we can talk about is wound debridement. That is one of the treatments we can do, removal of dead tissue. So PTs can perform what's called selective debridement. That's use of scalpels and tweezers, called sharps Just collectively, they're called sharps. So we can use tweezers and scalpels to get in and pluck out dead tissue. Pretty fun if that's your kind of thing. Not mine. Could. Or application of specific medications. There are some specific medications that will eat away at dead tissue depending on what the organisms are. So PTAs cannot perform selective debridement, but PTAs can perform wound care just with non-selective means. So non-selective means whirlpools. So wound on the leg, stick the whirlpool in the leg, turn on the water, and the circulation of the turbine, the water moving around, will help get rid of some of that dead tissue. But it's called non-selective because if we're removing the dead tissue, what also are we interfering with? Some of the new fragile tissue that we do like too. So we could also use, this is called a pulsatile lavage. So this head here on here. So this is just a super soaker. This is like a really small, lame super soaker. This head here is about the size of a quarter. So what's great about this pulsatile lavage, whirlpool, one, we gotta have a whirlpool. Two, we gotta fill up the whirlpool. We got to get the patient to wherever the whirlpool is. We got to get their anatomy in the whirlpool. If our patients have these kind of wounds, first of all, how is their mobility? Poor, because if they had good mobility, they probably wouldn't have gotten the wound in the first place. So that's a lot of work. Oh, and then guess what? We got to clean the heck out of that whirlpool after we use it. This pulsatile lavage, we bring it in, we plug it into the sink, we squirt them right at bedside. This can all happen at bedside. And most of these have like little tents, like plastic tents over it to contain splatter. That's fun. It's both. It's a pressure washer with a vacuum element to it to collect the dead tissue and also reduce the mess. Now, pressure washer is a bit excessive. This is 4 to 12 PSI, less than what most kitchen sinks are. Is that right? Yeah. So anyway, it can be, but we bring a bunch of towels and drape around our patient and squirt them with it. But also because this also has a vacuuming effect too, it can reduce that. But it's a heck of a lot better than dragging somebody to the whirlpool. The other thing we can do, this is pretty fun, wet to dry dressing changes. So we grab a big chunk of gauze and we put saline on it. And we put that wet saline gauze on top of the wound. And then we let it dry. And you already know what's going to happen next. And then, because I'm so excited about it, we take that and we say, hey, Larry, how's your day? And we rip that off. And with that now dry dressing comes off all of that dead tissue and some of the good tissue too. So that's the downside of non-selective treatments, is it can interfere with good tissue as well. But that's pretty fun. Not really for the patient, but it's pretty fun. They can't feel it anyway. They got a pressure wound because they can't feel it anyway. What was that sound? Nothing. All right. Next up is vascular insufficiency wounds. So now the anatomy, there's poorly functioning arteries or veins. Arteries bring blood flow to the extremity, veins bring it away. So arterial insufficiency wounds, those are going to happen in at the smallest blood vessels, so the most distal. So arterial insufficiency wounds happen at toes. Venous insufficiencies happens because there's a pooling of blood. If we were to think of that guy with the hemosiderin staining at the beginning, there's a pooling of blood there. That excess pooling of blood is inhibiting the tissue from getting the skin from getting the nutrients and oxygen it needs, which causes skin breakdown. if we know our vascular anatomy, where's the greater saphenous vein? Medial leg, right? You guys just nod and say, yeah. So these wounds are going to occur just proximal to the medial malleolus of the ankle. So there's some sort of narrowing or blockage of that artery or vein that's causing this. With veins, we also have these backflow valves. And if those valves prevent, blood squirts up, and then these valves flap down and they prevent the blood from just falling back down. But if that valve does break, that blood is just always going to slosh and it's never going to actually traverse its way. So that's the other mechanism of that. These are progressive, lifelong problems. The wound itself we could treat, although I will tell you, the condition is lifelong, right? Arterial venous insufficiency. I will also say that arterial insufficiency wounds, once you get them, you're at a high risk of amputation, because we just don't have the blood supply to heal the wound. You got a wound because you don't have good enough blood supply. What's going to heal this wound if we don't have blood supply, right? So high risk of amputation. So treatment is, prevention is number one. So patient education to stay away from space heaters is definitely the thing we have to do. If our patients have arterial insufficiency, there's not enough blood flow to the feet and toes. Do a skin screen for me. What's one of the T's is temperature. What's their temperature going to be? Cold. So they sit next to space heaters because their feet are always cold. It doesn't matter what the temperature of their house is, their feet are cold. How close are they to those space heaters? Right next to it. What's going to happen if they accidentally make contact? They're going to get a burn. Is that burn going to heal? No. It's not going to heal because we don't have the blood flow to heal it. And then what happens then? Amputation, right? So stay away from the space heaters. Self-inspection of feet, making sure there are no wounds. If there is anything, we got to address it quickly. Gradually increasing exercise tolerance. That can be really helpful because we can improve blood flow a little bit if we improve exercise ability. For venous insufficiency, patient education, anything to decrease swelling. Elevate the legs, compression stockings, exercise, especially exercise. If we can elevate the legs and do exercise, ankle pumps, that will really help that venous return. And lastly, scar management. Again, the cosmetic appearance of our patient's skin is going to be one of the big things on their mind. Is this going to scar? That it will always be. It doesn't matter what the type of problem to the skin will be. So any mechanism that impairs the skin, physical injury, burns, surgical incisions, static and lifelong, but with careful consideration on stage of wound healing, right? So that's why knowing the stages of wound healing matter, because we want to know what treatments can we do and when. Positioning to prevent contraction. So what this means is if I have a skin problem, a burn over my elbow, my front of my elbow, if I let that skin heal with my elbow bent, it will heal in a contracted state. I'll never be able to extend my arm because that skin will just develop to be so taut. So we have to educate our patient how to position themselves so they're at think of sleeping in the fetal position. That's called position of comfort. So we want to teach our patients to stay away from positions of comfort. We want them to be fully extended on that. So positioning to prevent contraction of the skin. Potentially splinting could be it. So positioning is just, hey, lay down in bed just like this and you'll be okay. Splinting is now adding a bracing that won't let that happen. Passive range of motion to prevent scar contraction can help as well. Active exercise. Some pressure garments can also help decrease with the hypertrophy of the scar. Those are really helpful, especially with burns. And then education to protect from sun damage is another really important thing. I had two patients, they had surgery, they were back to back in the hospital by the same orthopedic surgeon. They both had ACL repairs. One was at 6 a.m., the other one was at 6:35. They were back to back. I told them both, hey, if you keep this, they were young high school females. I said, if you keep this out of the sun this year, these incisions will fade away to next to nothing. You guys will have, there'll always be a little something, but it'll fade away completely. One girl put little band-aids over every single little incision that there's like 3 incisions that she had. She put band-aids, so she had a funky tan line for the summer, but she put band-aids over it, faded away next to nothing. The other one did not and worked on her tan all summer long. And those incisions darkened up like you would. She'll always have prominent scars because of how important her summer tan was when she was a sophomore in high school. So really educating our patient from sun damage, and especially if it's post burn, it can cause some real serious problems to that. So, all right, do we have any questions on integumentary? All right.